Hello and welcome to a special episode of the RN Mentor podcast and Nurse Vitals PRN combo. I'm going to start with some introductions with the individuals that are joining us this today. I'm going to start with my co-host for this episode, Lorne Carrol. Lorne is a public health nurse from the state of Alaska. He is a Johns Hopkins Fellow with the Bloomberg American Health Initiative, chosen to be an American Journal of Public Health think tank member in 2021, and past president of the Alaska Public Health Association. I also have Dr. Aisha Mix. Dr. Mix is a captain in the U.S. Public Health Services, U.S. Public Health Service and Services, as a senior health policy administrator for the U.S. Immigration and Customs Enforcement Health Service Corps. Dr. Miss has served as an assistant surgeon general and a 12th chief nursing officer in the U.S. Public Health Service. We also have Dr. Susan Hayes. Dr. Susan Hayes Little. Dr. Susan Hayes Little is a North Carolina Department of Health and Human Services chief nursing officer for the public health portfolio. We also have Dr. Joyce Edmonds. Dr. Edmonds is a director of midwifery and reproductive health at ZHW and a senior research scientist at Ariad Labs at Harvard School of Public Health. She is the immediate past chair of the APHA Public Health Nursing Section. She is also the editor-in-chief of the Journal of Obstetrics, Gynecology, and Neonatal Nursing. We also have Dr. Krista Jones. Dr. Jones is a clinical associate professor and director of the University of Illinois Chicago College of Nursing Urbana campus. Dr. Jones serves as chair of the Council of Public Health Nursing Organization, president of the Association of Community Health Nursing Educators, and chair of the Illinois Nursing Workforce Center. Also, I want to recognize Dr. Jamie Watts-Isley, who is not joining us today, but she was essential in putting this group together. And she is a public health nurse and faculty member at UNC Greensboro, who leads the coordinated efforts for this incredible panel. So thank you everyone for joining. I'm going to hand that off to Lauren, and we're going to get this conversation about public health going. So welcome, everyone.
Thank you so much, Ali, and welcome, panelists. And also, special thanks to Ali and the RN Mentor podcast. I understand you just had a 4th birthday, so happy birthday to the podcast, and thanks for this platform. So panelists, we're going to jump right in. We have 4 kind of main areas, and I'll address each of you with a question. I would just encourage the rest of you to hop in. So let's get started. Kind of the 4 areas that we'll touch during this hour. So we'll be workforce. Who are we as public health nurses? Our competencies, enumeration, and then 4th and lastly, let's touch on our workforce shortage, and how we're going to move into the future. So first off, Dr. Aisha Mix, could you speak a little bit about who we are as public health nurses and touch on how we tell our story?
Thank you for that, Lauren. Always a pleasure to join my very esteemed public health nurse colleagues. So it's funny, when people ask me that question, I always tell them the very simplified version first, right? And I tell people, you understand that nurses care for patients, period, right? As a public health nurse, our patients happen to be populations. So instead of doing the same work that we normally do for an individual, we actually have elevated it. And so our impact and our focus are on segments of populations or entire populations themselves. So when I explain the work of a public health nurse, I get people to understand that as a nurse, we're responsible for addressing people's engagement and their response to their environment and how that intersects with health. So when you look at that as a group of people, that's who we are, right? That's how we actually engage and interact and support the healthcare system. So public health nurses then have populations as patients. And what we're there to ensure is that we're alleviating suffering, we're addressing needs, and all of the work that we do is targeted to and linked to those specific needs so that we can have the most positive and optimal outcomes, again, just as for individual patients that are identified by the populations that we serve.
Thank you so much. Dr. Susan Little, did you want to chime in on that from your perspectives?
Yes, public health nurses. So I've been a public health nurse myself since 1996, so a number of years, served in various roles at the state, local, and actually international level. And what's I think so unique about public health nurses is our ability to be flexible and look at health from an individual all the way to a population level. And every time we even look at an individual in clinical care, that if we may be working in clinical care, it is always from a perspective of the population that we're providing that clinical care.
Thanks so much. Dr. Edmonds, you bring a unique set of perspectives. You've been in the field for a while. What might you add?
Thank you. Yes, I've had the privilege of working as a public health nurse prior to my academic career and the local, state, and federal level. And I always describe public health and the specialty as the ability to sort of zoom in and zoom out, like Dr. Little said, that ability to sort of look and meet individual families, where they live, work, and play in their communities, being a trusted source of information. But then also zooming out and understanding the systematic and structural facilitators and barriers to health, and operating in that space, both, at the individual family level, but at that policy level, thinking about changing organizations, the structures, the laws, the regulations, that shape our health.
Got it. And Dr. Krista Jones, I'd like to pull you into the conversation. And I want to ask a very broad question. When you're working with students and you're kind of thinking in that space, but you're also thinking about core competencies and scope and standards of practice, what things come up for you when you're working with students?
Thank you, and I appreciate the time to be here with this esteemed colleagues on the panel. We look at public health nursing practice, certainly as others have stated, promoting and protecting the health of populations, using knowledge from a holistic standpoint, nursing, social, and public health sciences, and focusing in on how we improve the population health, whereas many of our other curricular courses perhaps are focusing in on the individual level. And we're really looking at how do we look at things like, herd immunity, for example, or, what is the detriment upon a population when so many individuals within that population are suffering from same diseases or diagnoses or other types of chronic conditions and things, and how do we address that? And how do we address both equity in terms of care and equitable resources in communities that are more marginalized and disadvantaged. And so with students, we talk about all of these various social determinants of health that impact not only the health of the individual, but the overall health of that entire population. And what are the resources that can come to bear to address those issues and concerns? Where are the limitations, and where can we best and most effectively apply funding to assure that the resources are where they are needed most?
And I'd like to just build on that, excuse me, but I just think that we are, as a sort of specialty, while we're small, we're miney, because we can be flexibly deployed. We have a range of advanced knowledge and skills that allow us to move in and out of different places, that it's not just isolated to like a unit or a hospital. And I think that really makes us unique.
I'll add on that, Lorne. That's one of the things that I think is so important about public health nursing is our flexibility to move in and out and pivot into the different roles, whether we're working in clinical or whether we're working in policy, whether we're working with communities, with whichever role we might be working in. Public health nurses have that ability to pivot. And when I'm working with the nurses in North Carolina and the nurses in across the nation, when I have that opportunity, I talk a lot about how one of the joys of public health nursing is the ability to be able to pivot. We may be working with that individual patient or family one day, and the next day we're writing statewide standing orders for COVID vaccines. It's a very exciting career and profession because it has that ability to move into different realms of practice.
Now, I have something to disclose. I'm a little biased because I have also been a public health nurse for a while, but I have a question. This sounds exciting to me, but do you think students are getting the full picture of what public health nursing is or could be? Dr. Jones.
It's a great question. So one of the things that I think is critically important is whom is providing that instruction, to students within those courses. Many of us have talked about our years of experience. I myself have just celebrated last year 30 years as a population health and a nurse working in various settings in the community. So we want to engender a passion in students for this work. So we have to get them into all different types of settings to which public health is all encompassing. So it's correctional nursing, school health nursing. We're looking at, federally qualified health centers and health departments and community agencies and, everywhere in which environmental and climate influences are occurring. That's a part of public health nursing. We were just talking about the COVID pandemic and disaster preparedness and all of these other, as I said, social determinants and other influences. There are lots of opportunities to practice population health nursing. And so we want to have individuals in the classroom that come with an understanding of the skills and the competencies needed to practice in autonomously and independently in many of these settings that we're all discussing and can provide leadership in these settings. So we have to give students exposure, but we also have to have individuals who have that knowledge and capability and talents in those areas to provide the information that students need to be able to be adequately prepared to assure a competent public health workforce. And what we find in some of these, and some institutions, is that oftentimes individuals are asked to teach these courses without a lot of experience in these public or population health areas. And that can therefore then be detrimental on whether or not students receive that adequate knowledge and information to adequately prepare them for these settings, and most importantly, to engender a passion for them to go into that field.
Lauren, really quick question, and anybody on the panel that you want to chime in. I'm going to put my academic hat on for a second, because most associate degree programs, I don't think, well, I would say all associate degree programs pretty much do not include a public health component in them. I know in California where I teach, there, it's part of the bachelor's degree program, and when you complete it, you can apply for your PHN certificate, and it's part of that process. And I'm happy to say the board recently blessed everything, and for the next couple of years, it's free to get that certificate. So thank you, California for that. It used to be, whether it's initial or renewal. But I have a question, just because, like, for example, the new essential curriculums came out for baccalaureate degree programs and master's degree programs. Do you think the accrediting bodies need to be more purposeful in saying ambulatory care nursing needs to be integrated into all programs, whether associate degree, bachelor's degree? Because I think one of the issues we have is we have faculty that only have acute care setting experience. As a result, and NCLEX is all acute care setting. So is there an opportunity for us to say this ambulatory care needs to be integrated, as opposed to just making these generalizations of public health, DEI, underserved? Like, those are the key words, but nobody's saying ambulatory care, and everybody's kind of deferring to acute care setting, or not really mentioning public health or ambulatory care in that concept.
I'll just respond to that. I think that's a really interesting question because, like you mentioned, associate degree programs and baccalaureate programs traditionally were very different based on whether they had a public health nursing and then a leadership component. Now that is changing. And I would say that the one thing that's consistent is the inconsistency. So much like healthcare, there's a wide variation in the quality of programs and the ability of programs to have trained faculty as well as dedicated practice partners who have the relationships with those faculty. When you talk about ambulatory care, I think it's like you're starting to get into this idea of setting. And I would really like to see public health nursing move away from being defined based on setting, because like we mentioned, we're able to practice in multiple settings, whether it's in an inpatient, an ambulatory, a clinic, a neighborhood, you name it. And so I don't necessarily think that we should move forward with thinking about competencies by setting.
Yeah, thank you for that. Yeah, and I work now I'm at FQHC, so we have that community outreach arms, with mobile health clinics and things like that serve like the underserved and homeless populations. So yeah, I completely get it. But those are like two areas when we're looking at moving away from that acute care settings, and that's why I kind of put them both.
And we've been talking about this for years, and I don't think nursing is the most progressive in relation to its curriculum and its movement forward. And again, I think there are some schools of nursing that really have excellence in this area, and others that don't. But getting better criteria for what we're talking about when we talk about these population-based competencies, and getting people to have a elevated understanding of that is definitely needed.
Yeah, thank you for that.
Yeah. What I'll add, as I always think about that, and even going back to what Dr. Jones was mentioning, it's not so much a public health course or a community health course. I think, where we have an opportunity both at the associate degree level as well as the baccalaureate level is to help people elevate the thinking so that we don't stop at just considering the patient and the family. But no matter what the conversation we're having, we still link it and go even further to talk about the population health impacts, right? Because it could be simple things, right? Whether you're in your maternal child health class, there are aspects of that are very specific to individualized patient care in a hospital. There are other aspects that have something to do with other settings. But even beyond that, there's everything that has to do with bringing in the social determinants of health and the entire population level context in order to provide care for that person and that family. And so being able to infuse that into each and every course and having students have that exercise in critical thinking, because to me, when you're in a pre-licensure program, regardless of what degree level, it's really setting the stage for where you're going to springboard. when you are a bona fide, and I say bona fide because I see public health nursing as a specialty, when you are a bona fide practicing public health nurse, you've actually reached the highest levels of these particular competencies, and you're able to apply them no matter where you are. And so if you learn the basics and you understand what that looks like, for some, that may become their calling. For others, it may not, but guess what? They've been exposed to it, and so they understand it. And so what my hope is that if you instill that at the pre-licensure level, they have that much more appreciation. So they will then seek out those who are expert in the area, and then the public health nurses will be utilized way more than we currently are. But I think that that really is the gap in infusing it entirely in academia, and then being able to link academia and practice, because as long as they're considered these entirely separate entities, we'll never move the needle. So I think that that is the first step in just making sure that, you know, when we're talking to universities, colleges, we're not talking about how can we give you a course. You know, it's beyond just the course.
I'd like to add, so I appreciate so much that I was invited to bring the voice of practice from North Carolina's public health nursing to this conversation. And while I can't speak to accreditation of BSN or ADN or diploma programs, I can talk to what it's really like out there for public health departments and other health agency who wish to hire public health nurses. There is a belief that the minimum entry level into public health nursing practice is a baccalaureate degree. And that's evidence-based and everything. But the reality of it is, I'll take North Carolina as an example. The majority of new nurses who graduate from nursing schools in North Carolina are from ADN programs. We're a very rural state. The majority of our nurses in North Carolina are ADNs, and the majority are working in rural areas. So there is not an option in many of our counties to be able to hire BSN prepared nurses. So what we've done in North Carolina is really look at our public health nurses and those who are interested. And we have had, for many, many years, many decades, administrative code that stated if a nurse becomes a public health nurse in a local health department, if they do not have a BSN, they have to take an introductory course in the principles and practices of public health and public health nursing within the first year of practice. But what I've been hearing for over a decade now that I've been at the state level is that after those non-BSN nurses take that course, they are more prepared as a public health nurse than the BSN prepared nurse. So we've taken a different approach in North Carolina because we don't want our non-BSN nurses to feel marginalized. We need them. They are holding up, at least in governmental public health nursing, they're holding up public health nursing in North Carolina. So we have a new public health nursing credential program that allows all public health nurses and governmental public health to take this course within their first year. And that's equalizing the baseline fundamental information that all the public health nurses have. It's also addressing what Dr. Edmonds talked about, which is the consistently inconsistent education about public health nursing in the BSN programs and in the ADN programs. And it's been very popular, extremely popular in North Carolina. And it has helped address competency differentiations that we were finding all over the state.
I just wanted to add something onto that because I don't want us to leave with, everything is bleak, right? And I'm really kind of, we've brought out, here's the challenges, here are some of the concerns, but, we're really facing right now a new paradigm shift. On the heels of the Robert Wood Johnson Future of Nursing Report, the American Association of Colleges of Nursing has put out the new essentials. And the essentials are really calling for a shift away from greater investments in acute care to moving into how do we reinvigorate public health values and principles in every single course, to what Dr. Mix stated previously. It has to be intertwined throughout the entire curricula. And right now, colleges and universities of nursing across the United States are re-envisioning their curriculum. And, there is a call for asserting that in each of these courses, they develop a set of curricular competencies that allow opportunities for students to develop interventions at the individual level. You're looking at the family level, the community level, systems level, and population levels in all of those courses. So I think we're really poised, knowing that those requirements have come forth, to work with colleges and universities across the United States to support academic practice partnerships, clinical partnerships, mainly to what you're referring to, Dr. Little there, so that we can prepare students to address the issues of today and tomorrow: racism, poverty, climate change, environmental injustice, violence, chronic conditions, on down the line. I think it's a really wonderful time for public health nursing right now, post-COVID. Certainly where we were all called, to act, but to really act now about changing education.
Thank you, folks. Before we move into enumeration, I want to ask both Dr. Mix and Dr. Little, we may have folks listening to the podcast that are nurses or brand new public health nurses. So I'm just curious, what are you seeing that engages the workforce, especially the newer folks that are coming on that haven't had years to kind of develop their practice into a bona fide practice, as Dr. Mix was mentioning? So is it do they connect with competencies? Do they connect with the challenge of prioritizing workloads? What is it? What is it that you see that your employees and team really connect with that keeps them in it and makes them want to learn the specialty?
I'll start with that. So we all know that nursing is a calling. And I think that we as nurses, as we're in nursing school and as we progress through our career at different stages, we are even called to subspecialties or specialties and subspecialties. I was called very early on in my nursing school career to public health nursing. And what I've found in myself, I've seen in many, many others, is that being able to meet the individuals and the families where they are, even in their homes, in their pantries, educating pre-diabetic or pregnant women with gestational diabetes about what works in their pantry for their nutrition and what doesn't. It's the opportunity to get to meet these patients and families on a different level than is experienced in the acute care center and setting. I believe that there are many nurses who are not drawn to public health nursing, as I and many nurses were not drawn to acute care setting. So I think it's a servant heart. I think it's the awareness of what Dr. Mix was talking about and others about the social determinants of health and how they really ecological influences on health that you really are able to see and address in public health nursing practice.
And I would actually echo a lot of basically all of what Dr. Little has said. And I will also add that from the federal public health nursing workforce, it's also the ability to influence change. So at our level, many of the nurses at the federal level have an opportunity to engage with policy and program development, which are other aspects of public health nursing as well. And so we see it from a different perspective in that we have an impact on things like resource allocation, because we know that those things make a difference for communities. But in order to actually do that and be a part of that, you have to be able to assess the needs of a population, right? And those are the things that we bring as nurses, is that ability to bring the voice, advocate for the communities, understand what their needs are at many different levels, tying in those social determinants of health, but then being in a position to actually be in action. So what draws many of the federal public health nurses, many will tell you that I came into the federal government because I wanted to be a part of the decision making to make sure that folks were understanding what's happening out in the community. That was my calling as well, right? In addition, as the uniform service within the public health service of HHS, we also have the opportunity to engage in emergency response, disaster preparedness and things of that nature, which again are part of public health nursing competencies. But when we deploy in that manner, we again are addressing the needs of the population and the impacted community. So we have a subset of nurses who can deploy and provide that direct care, but we have even more nurses who can actually engage in the community collaboration, the development of work groups, cross-sector engagement, all of the other aspects of public health nursing that my colleagues have mentioned to you that are above and beyond the direct patient care that can be provided to one person at that particular given time. So it does definitely tie into what Dr. Little was saying, is that sense of purpose and service. And then again, when you have an opportunity to influence the change and actually make the circumstances better, we take advantage of that as well.
Thank you folks so much. Dr. Edmonds, I still, before we move on to enumeration, I have this question that keeps burning in my brain, and it's kind of related to Dave Beaumont's piece that they published in 2019 about, meeting individual social needs falls short of addressing determinants of health. So I guess a broad question might be, in your thinking, and as you're visualizing the future, language matters. So what are you seeing, and what do you think about the differences between meeting social needs and understanding what social determinants of health are and incorporating that into practice?
Wow, that's a tough question, but a good one. Thank you for that. Yes, language absolutely does matter. And I think meeting individual social needs is the duty of all healthcare providers working with individuals, but understanding that those needs have been created and they're or formed or shaped by these larger systematic social determinants of health. And I know that's another very popular term that has various meaning depending on, who you're talking to and how it's applied. But I think we have to go beyond meeting individual social needs to really thinking about the structures that shape that need. And how those structures are inequitably distributed in a society that then in turn, some people have more of those needs than others. I don't know if that answers the question or if any of my other colleagues can add to that.
In my experiences of things like cross-sector collaboration, it took me kind of a while to figure out that when responding to an immediate need, like access to medication-assisted therapy, folks are engaged because individuals and families need access to healthcare. Meantime, while I'm sitting around the cross-sector table, I'm thinking about determinants of health, and I'm looking to engage the folks to work upstream, but I discovered maybe those are different partners. And there's kind of a yes, like we all need to work on it and we all need to continue working on it. And would you folks like to chime in on that? Anyone else?
Yeah, I'll chime in. And I think what you've described is that perfect connection between public health and nursing, right? Public health automatically brings the conversation upstream, right? To exactly what Dr. Edmonds was saying. You may have that immediate need for that person, but you have to actually think beyond that, right? Someone is unhoused. Yes, they actually need a place to live. However, what are the circumstances that were existing in this community that led to groups of people being unhoused, right? And so when you move upstream, the immediate response is, of course, we've got to address that. But as a nurse, you're also taken to context, so how are people living in this situation? And what else is it impacting? To your point, that may actually be the reason why they're not accessing care, because I actually don't know where I'm going to go to sleep tonight. So you have these multiple and competing priorities that individuals are facing. However, when you move it upstream and then you turn it into a conversation that is the voice of that population, therein lies public health nursing. And I think that is an important distinction between identifying, a person's individual social needs and addressing social determinants of health. But that's also a perfect example of helping people understand the difference between public health nursing and acute care nursing or direct care nursing. Those concrete examples I find are often helpful to help people understand the nuances that differentiate, and also help people understand that neither of us can do it alone, right? We have to work together, but we're working differently. And I think that that's what brings us to the best results ultimately.
Great. I'm going to chime in real quick, and just because, I'm hosting air coding. This is something that normally is not translated well in the academic setting, unfortunately, and I think that's one of our biggest issues, that we're not really talking. We're bringing in populations, but we're not really. And even after I finished, I think I was in my PhD program before my light bulb went on about what social determinants of health is and what population health is. And it took me a while to get there, just because my setting was not the correct setting for me to really understand. And now that I'm at FQHC, all kinds of light bulbs are going off in my head, because we have an arm that is engaged with policy from a California, Sacramento to national DC. And the population that we're serving is 70+% Hispanic. Our workforce, however, is also 70% plus Hispanic, and our clinics are in the communities that our population comes from, right? So that's a huge difference than individuals who are working in the acute care setting, and their patients are coming from all over the place. And you as an individual aren't necessarily living in those communities and don't really understand. So when your workforce is from the community that you're serving, I think also makes a huge difference, because you have that understanding of the needs and the drive to make the changes automatically. I think with appropriate resources, also drive some of the changes you're trying to make within those populations. So I think somehow we're missing something, definitely in academia, but in practice, and the core of nursing, and I always tell those people, the core of nursing is population health. It's not the individuals you're touching, but the populations that you're engaging with. And I think that's a key component that somehow needs to be translated into how we're preparing the workforce moving forward.
And I'll dip into perhaps a little political discussion, but I think it goes beyond academics. I think we live in a very individualistic society where we're not thinking about the greater good. We're not thinking about the whole. We're thinking about ourselves. And we have structures and finances and a system that supports the individual.
Yeah, definitely great. Thank you.
Well, I'm sitting here thinking, it took me a while too for my light bulb to come on, and it takes time and space, and also things like living locally and working with local populations can be helpful. But at the same time, while prioritizing the needs of a community, it can be challenging. For an example, if there's a syphilis outbreak, that can shift priorities immediately, especially if the syphilis outbreak is being managed at the same time as a pertussis outbreak and preparing for, say, measles. And so this kind of brings up the question is how many public health nursing folks or public health workforce is needed. So the subject of enumeration, I want to ask each of you, get each of your perspectives. What is enumeration? What does that mean to you folks? And what are the pros and cons? And what do we need to move forward?
Well, I'll start responding. I mean, enumeration is really thinking about counting, quantifying who's doing something, how many PHNs, for example, there are, where are they, and more importantly, what are they doing? And so it's really about thinking about our workforce, it's supply and demand, and it's really thinking about the current supply so we can come up with an optimal way to think about population PHN ratios for optimal health outcomes. But unfortunately, I think the issue is because even though we're having an increased ability to communicate the value of public health nurses in terms of the impact that they have on communities and health, we don't have a reliable way of determining how many PHNs there are and what they're doing.
We, and as I'm sure many, many other states, have such a nursing shortage. And when you layer that with our very rural state and access to nursing is, nursing staff members is being able to recruit and retain has so many challenges. For me as a chief public health nurse and for the nursing administrators across the state, it is very difficult to advocate for public health nurses, having an adequate staffing level of public health nurses, when there is not a known formula. And during a nursing shortage, there is risk that public health nurses are replaced with licensed practical nurses or credentialed EMT or even MAs and CNAs. And we all know that they can't carry out RN scope of practice. And I think that causes issues for being able to carry out the public health mission and what we're required to do by law and rule when we don't have an adequate number of public health nurses. So in the practice world, it's very difficult not having that formula like they do in the acute care setting to be able to use to advocate, because leadership, they like statistics, they like facts, they need your ask to be supported by facts and numbers and evidence.
Yes, and we have a lot of evidence from Linda Aiken and many, many others that have established like the RN to patient staffing ratios, and we don't have the equivalent of that in public health, but we are working on it. And all of us and this team, in fact, have a partnership that involves CPHNO, the U.S. Public Health Service under Dr. Aisha Mix, Susan Little. We are all working on this important issue of enumeration. And the reality is public health nurses, we're 2 to 6% of the total RN workforce. It's a relatively small specialty, right? But it's an extremely important one, and more resources are needed and efforts to really accurately be able to capture and count PHNs.
Yeah, I was just going to add to that, Dr. Emmons, as well. The latest statistics that came out in 2020, there's been a decline from 4% of the workforce. If you think about the entire nursing workforce, acute, ambulatory, population health, school nursing, everything, 4% to 2.9% in 2020 at the start of the pandemic. We certainly know across the board, there's an estimation of 5% of the workforce left post-pandemic. So, dwindle away, even more, after that. So certainly less in terms of numbers, to address needs. Goodness, if we would ever have another, pandemic in the next couple of years, would we still have to rely like we did before on lots of retired nurses coming to the assistance of everything from assessments to vaccinations to dispelling myths and rumor in communities and neighborhoods, to engendering individuals and motivation for people to be a part of the process from businesses on down the line. We also know that there are significant disparities in salaries. So if you look at U.S. Bureau of Labor Statistics, public health nurses on average make anywhere from $8,000 to $20,000 less than acute and ambulatory care counterparts. And to Dr. Little's comments before, what we're finding in the research and the data now is that our generation of nurses that saw this as a calling, those numbers are now starting to dwindle. And now we're seeing, Gen Z, Gen X nurses, new nurses coming into the fold who are really looking at balanced lifestyles, balance with, personal life and work. And, what am I going to be, required to do? What's the flexibility in time? And also, what am I going to be paid? And so we have some of these barriers and challenges that we, have to address from a salary standpoint, from an enumeration standpoint. And the other thing is those numbers that I just gave out are only those that we've been able to track. To Dr. Emmons' point, there is no consistent way in which community population health nursing is defined to get that number. Are you counted in that number if you're in a school setting? Are you counted in that number if you're at an FQHC? Are you counted in that number at a health department? And the way everybody defines that is different. We're currently in my state in Illinois, we're doing our registered nurse survey right now because everyone has to renew every 2 years. And we have lots of different settings that are listed for individuals, but we're finding that some of the nurses themselves don't even see themselves in those categories. So they are truly working as community population health nurses, but they're searching to put themselves somewhere else. And so they're not truly, being counted. And where we know we have significant gaps, we also see some overcounting, where people are saying, in acute ambulatory care settings, well, sure, everyone here is a population health nurse, but are they really addressing, back to our previous comments, individual needs, or are they truly addressing community population health needs? So there has to be some standardization.
And it also gets into what exactly are they doing? So regardless of where they're working, like what are their functions? And that's the piece that is missing.
Yes.
Yeah. And I think one of the other things, I've been in this conversation of nursing workforce, nursing shortage, et cetera, for the bulk of my nursing career. And even from a federal level, it remains a challenge. So I'm not sure if you all are aware that, the National Sample Survey of Registered Nurses, the newest report was just released, right? So that's been released. There's always been the conversation and the questions about a shortage, because a nursing shortage does not exist everywhere. In some places there is a surplus of nurses. In others, there are hardly any nurses. And so when we talk about having a nursing shortage, it always has to be mentioned with the caveat of who you're talking about and where you're referencing, because it looks different, right? So whether there's a nursing shortage of public health nurses, whether there's an acute care shortage, whether there's a shortage in this rural community, those nuances are very, very important. And I think the other aspect that makes it challenging as far as determining the number of nurses and when you have a shortage is because the number of nurses that you need is directly correlated with the needs of that community. And so if you're not assessing the needs of the community and how to meet their needs, and then identifying how many nurses you need, you're doing it backwards, right? So it's very difficult to say that community A needs 10 nurses and community B, just because community A did, they need 10 nurses also, without actually assessing the nuances that make the populations or even the patients different. We're missing the mark. And I think oftentimes, nursing is struggling to fit into a model utilized by other healthcare professions or other sectors in general, and it just does not fit. Now, I say that also knowing that we often don't have the time or the resources to do it the right way. So, I still believe that this conversation of nursing workforce is a public health issue. And so as public health nurses, understanding and identifying what workforce is needed to meet the needs of a community is a population health discussion. And I think that's an important aspect where public health nurses are not pulled into identifying and designing strategies to meet the needs of whole communities. We're asked to meet the needs of individual people. And oftentimes we're not a part of the decision making in order to really, really assess what's needed for a community, because that will tell you whether you have enough nurses or not. And that's public health nurses, acute care nurses, or any other type of nurse. Because as the nurse strategizing for a community, you understand the continuity, the continuum of health, and you can figure out what workforce is actually going to help to meet those needs.
A public health nursing mentor of mine, Tim Struna, once he kind of outlined that when engaged in its entirety, public health nursing practice is a very important tool for improving and protecting population health. And then the pandemic came along, and the public health workforce really focused on that novel virus, and non-communicable diseases were, left behind. From that perspective, so it kind of brings up the question, and you've all touched on it, but I want to ask in a different way. So that the question is, why is there a shortage? Why don't we have enough public health nurses?
I believe it goes partly to what Dr. Edmonds spoke about, is that while a public health nurse can clearly define what he or what they do, in general, there's not a clear definition of what public health nurses do that is understandable or by non-public health nurses. So APHA, American Public Health Association, Public Health Nursing Section, and many other lead nursing organizations in the United States have adopted a definition, but I think it needs to be updated so that it is understandable outside of our profession. And we definitely, as Dr. Edmonds and many others spoke about today, need to get as far away from setting as part of the definition as we can, because that is limiting us.
Mm-hmm. Yeah, and I would add to that I think the way we reimburse in terms of the way healthcare is funded is still at the very much at the individual level. And so thinking about block funding, thinking about reimbursable services that are tied to these unique public health nursing functions would go a long way to having more open positions available in at least in governmental public health.
Yeah, and I think the two of you together, I think what you're also pointing out is understanding that public health nurses can work in many different capacities. And the job title, if you will, doesn't have to say public health nurse every time. There are many roles, many job titles, many positions that can be held by public health nurses. And I think that also becomes a barrier, because oftentimes, the public health nurses are not recognized until and unless the title says such. But when it comes to higher level opportunities, executive level opportunities, oftentimes the public health nurses are overlooked because those job titles are not called chief public health nurse in many states. And so we've got to do a better job of ensuring that people understand that the restrictions that are imposed that prevent nurses from holding positions actually prevent the nursing perspective at the decision-making table.
I'd like to touch on what Dr. Edmonds talked about as far as reimbursement. In North Carolina, starting in the 1990s, we created this novel role for public health nursing, public health nurses. It's called the Enhanced Role Registered Nurse. Now, it's clearly in the clinical area, but through a partnership with Medicaid, they are reimbursed for the work that they do. It's all the work that they do has to do with they work under standing orders, and they're assessing, evaluating and treating patients, all within the legal scope of practice. And it's wonderful because it really generates income for local health departments, and it's exclusive to local health departments. But if that's one role that, at least in North Carolina, we've been able to make that work. But the clinical practice, and that's only one small part of clinical public health nursing practice, clinical practice and all the other roles and functions of public health nursing are just as important as that individual clinical care for the overall population health and care of the populations. And until we're able to, as Dr. Edmonds said, identify a way that validates the importance of the work that public health nurses are doing inside and outside of the clinic, out in the communities, with populations in different settings and with different groups, we're not going to be able to get the recognition that public health nurses deserve and the recognition of the importance of the work that they do. I think it's that recognition is tied to reimbursement.
I agree. And I would say, it's a twofold issue. One, robust curricular reform in academic institutions that embraces community population health competencies throughout all courses within the curriculum, that provides students opportunities to experience the role of community public population health nursing so that they will be exposed to it and perhaps develop, not only an appreciation, but an interest in the role. And then the jobs have to be there. So this is the second part, the jobs have to be there, and the equity, as I talked about, in disparities that exist currently in what community public population health nurses are paid to peer counterparts in other specialties. So, that's part of it. And the other thing I didn't touch on previously, though, was, previous to the pandemic, funding in public health across the board in all sectors had been going down for years. And so, institutions, don't have opportunities for positions for nurses. And to Dr. Little's point, some of them are, hiring other specialty practices to fill those roles because they can be hired at a lower wage than a registered nurse can be. And, that's created issues in many of our communities that we saw when, the pandemic hit. Unfortunately, a lot of those funds that were brought to bear have now been exhausted. And we kind of see this year, things are going kind of right back the same way in many of those institutions throughout, our areas, particularly in rural marginalized areas of the country.
So with our remaining time, shift gears here a little bit. I'm sitting here thinking about 9/11, Hurricane Katrina, H1N1, and 4 years ago up till now, COVID-19. It's been rough, but also there's a lot of upshots. And I'm kind of in chronic underfunding of public health and public health nursing. I'm kind of thinking some of the upshots are when you have a workforce that has very few tools, it develops an incredibly creative workforce. And that's a good thing. So I want to kind of start to wrap this up by asking you folks, over the past 2 to 3 years, what are some of the upshots in public health nursing that you've been thinking about and highlighting? And also, what do you think about the future of public health nursing? What are you re-envisioning as we move into the future? I like to save the tough question for the last.
No, I think that's great. I think one of the upshots is actually the people here in this room at this podcast and coming together and working together on behalf of the specialty, on the behalf of the population, And I believe there is growing consensus within the specialty, within public health nursing, about the key needs and priorities. And I think working together with our professional organizations, with our practice partners, with our leaders, with our colleagues in other nursing specialties, with our colleagues in other public health areas. I think that there is recognition of the public health nursing specialty, and people are eager to find creative solutions to maintain and enhance it. And so the vision is like, I'd love to see a really robust, strong public health nursing workforce where, where we can think about a population ratio that's meaningful, like one population health nurse for 3,000 people, or back to a neighborhood public health nursing model. So that would be my answer.
One of the things that I have noticed during the pandemic and since is that an upshot is that with the extra funding, many of the local health departments were able to bring in support for public health nurses and like such as medical assistants and things like that, which allowed the public health nurses to really start to work at the top of their license. And I think that when that happened and the nurses were able to use the nursing practice, the art of nursing, their critical thinking, they were really able to come up with some creative ways to address the pandemic. They were able to create new ways of carrying out the public health programs that they were involved in. And I've seen, while we've had a lot of turnover in North Carolina, I've seen a great amount of innovation happening because they had time to really use those skills, the art and science of nursing and the nursing process, because they were given support for the first time in many years.
I think that's a great way and a really beautifully eloquent way to say that, Dr. Little. I would say I have the distinct pleasure of being the chair of the Council of Public Health Nursing Organizations, and we bring to bear the preeminent nursing organizations across the country that are in population health. And we're working on how do we support each other? How do we collaborate together? How do we bring our voices together around a singular issue? Because there is strength in numbers and there's power in numbers, so how do we advocate for a particular issue? And, what change can we have? And, whether that be funding or, that be enumeration. Many of the individuals as a part of that group are here on this podcast today. And so working collaboratively together, it's really engendered additional partnerships. And, I would say, the other thing that has been, I think, of benefit to us is to take advantage of the fact that, COVID brought a lot of challenges, but it also brought a lot of opportunities for us to measure outcomes. Public health nurses making a difference. That has been a challenge. It's been a challenge for scholars for quite some time. And so how do we then translate that into everything that we do, from mom and baby, dyads to, working with the elderly, to working, on neighborhood councils, to addressing domestic violence and racism and poverty. I mean, there's all these things that we do that we don't measure, and we don't have the data to go back to funding sources to say, look and see what we did. We need more money because we did this. And so it gave us an opportunity to start quantifying things. And I think we can continue to build on that And I think that is the upshot is we can, our elevator speech is getting better defined on who we are. And, now it's kind of show me the money. So, we need to get to the point of show us the money so we can do what we need to do to improve the health in our communities.
And the only thing that I'll add to that, because those have been beautiful responses, is, continuing these conversations that connect the dots from the local, the regional, the state, and the federal level. Because oftentimes we're operating in vacuums, and when it's time to work together, we don't have visibility. And so, the nuances that are the same, nuances that are different, being sure that we're in communication so that when disasters occur, that's not the first time we're having conversations, right? The other is making sure that we're infusing leadership in all of these conversations. We have to continue to develop nurse leaders across all sectors, across all specialties, and in particular in public health nursing. And we want to make sure that we're creating that role and ensuring that people understand that they can aspire to sit in those roles and have those communications, have those decision-making, ensure that they expect a seat at the table. And if they don't have a seat, to bring a chair. And if they don't have space for the chair, to actually create their own table and have the conversations such as the ones that we're having today. So I think it really is that continued conversation, but we've made great strides in opening up the doors of communication, creating playbooks that people can plug and play in order to institute this work where they are. But I think even more importantly, remaining connected over these past 4 years for conversations such as this.
Wow. I have 3 thank yous. Number 1, I just want to thank you, panelists, for being available. Every time I've reached out to you folks, you've been there, and that means a lot. And also, thanks for everything that you're doing for your community. So you continue to inspire folks, and it makes a difference. Number 2, I'd like to thank Jamie Watts Isley for teaming up with me behind the scenes to do the nuts and bolts. But lastly, thank you, Ollie, and to the RN Mentor podcast for this platform. With that, I'll turn it back to you.
Thank you. Thank you, everyone. This has been, I've learned a lot, and I appreciate the work that all of you are doing. I'm humbled by the work that you're doing. It's a heavy lift. And just my 2 cents on this is I'm going to say I think public health nursing, along with some other nursing areas that are often go unnoticed, we have to realize who we're competing with, and our competition is really part of it has to do with academia, because academia is very acute care focused, unfortunately. And we're competing with the shiny IV poles and the beeping machines and the designer scrubs. So I think we may need a publicist at some point to, and I think something like the Johnson & Johnson campaign for nursing, I think that had a big boost. I think we would maybe we need to reach out to Johnson & Johnson and say, hey, can we look at public health nursing campaign? So that would be fantastic if we see that happen. Maybe if they're listening, they've got their own podcast. So I don't know if they listen to this one, but maybe we'll push it that way. All right. Well, thank you, everyone. I greatly appreciate everybody's time, and really, it means a lot to me for you to choose this platform to come and speak, and hopefully we can do this again. I think there's a lot more discussions to be had. Maybe we can do this on a regular basis. So again, thank you so much. And I want to wish all of our listeners a fantastic rest of your day, and we'll bring more content for you to tune into. Thank you so much, and have a great one.